and surgery often meant the worst of both worlds, the complications of surgery and failure. The Swiss AO in the late 1950s and early 1960s developed methods of anatomic reduction and absolutely stable fixation, which made fracture surgery safe and successful. Operative treatment, particularly in major intra-articular fractures, became the standard of care. What we taught was very successful, and indeed, it rapidly won over the world because it was overwhelmingly superior. There were many opponents, but the success was such that it became the accepted method. However, I must point out to you that the early years were not without problems. However, we learned from our mistakes and we continue to improve. In the early days, we taught immediate surgery before swelling. It had its consequence. The concept was to operate early, as quickly as possible, before swelling would develop. We failed to recognize the implications of high-energy trauma. It is above all an injury to the soft tissue envelope. A fracture should really be looked upon as a soft tissue injury with a broken bone inside. The most important decision that one makes is to recognize the magnitude of energy involved. And in treating, we must learn to differentiate low energy and high energy fractures and their different degree of soft tissue trauma. I will use my classification of tibial plateau fractures to illustrate. The type 1, 2, and 3 are just fractures of the tibial plateau. They are low energy most of the time, and soft tissue damage is minor compared to the high energy, and here early surgery is possible. The types 4, 5, and 6 are high-velocity injuries. They are not intra-articular fractures, but they're fracture dislocations. Much higher forces, soft tissue injury is great. The types and 4, 5 degree of soft tissue injury that will direct the timing and the eventual method of treatment. And these injuries may even threaten the survival of the limb. Thus, provisional reduction and splinting in an external fixator rather than plaster is important. Splinting with plaster allows the extremity to shorten, make subsequent treatment very difficult. It obscures the limb, it obscures the soft tissue complications developing. Thus, definitive treatment must be delayed. Here you see an example. On admission and 8 days later, we see that the seemingly innocuous injury has tremendous implications for the degree of soft tissue trauma and the ensuing soft tissue complications. The only emergencies that we have to deal with in treating fractures of the proximal tibia are open fractures, those that are deformed and are threatening the overlying skin due to the deformity, those with a compartment syndrome, those with vascular or neurological complications, and irreducible fracture dislocations, which we cannot reduce provisionally. Thus, allow me to emphasize, please recognize low velocity, the types 1, 2, and 3, and the high velocity fractures, fracture dislocations, types 4, 5, and 6. The high velocity fracture, early closed reduction, spanning in an external fixator, waiting for the soft tissue complications to evolve and subside, and then comes delayed definitive care. Allow me to deal with further guiding principles which form the basis for treatment. Pauwels, a German orthopedic surgeon, postulated that in a joint there is a homeostasis between articular cartilage destruction and articular cartilage regeneration. If the forces are too great, instead of articular cartilage regeneration, we face articular cartilage destruction. There are important conclusions from this statement. Stress is force over the area that it is exerting its influence. Therefore, from the early days, we taught anatomic reduction of the articular surface to maximize the surface area. The normal is the maximum that one can achieve. We must correct the axial deformity because it creates an overload, and thus we reduce stress and allow healing and regeneration. Why is reduction of stress important? Reduction of stress is necessary to allow healing of the articular cartilage. Articular cartilage damage is invisible to the naked eye. We cannot judge the damage which the force created. And articular cartilage needs time and a low stress environment. I emphasize time and low stress in order to recover. Nelson Mitchell, a colleague of mine, Canadian, working in Montreal in the early 1980s, studied the accuracy of reduction and the influence of stability of fixation on articular cartilage healing and regeneration. He used the rabbit's knee as the experimental model. The model was very simple, an osteotomy of the lateral condyle, and as you follow the top of the illustration from left to right, you see the osteotomy. You see at 6 weeks the knee joint with no reduction and no fixation, and what was once pristine articular cartilage is now hardly visible as a joint. If you carry out an anatomic reduction, but no fixation, in other words, instability, you see the fracture gap filled with white tissue, fiber cartilage. The last example is the one that teaches us the basic principles. Anatomic reduction and absolute stability At 6 months, we have an absolutely pristine knee joint. Histologically, Mitchell was able to show that articular cartilage does indeed regenerate and heal. And he was able to prove with electron microscopy that the tissue which is filling is properly aligned and is articular cartilage and not fibrocartilage or fibrous tissue. From this, we have anatomic reduction and absolute stability in order to optimize healing of the articular cartilage. We are living today in an era of minimally invasive surgery, and we must look very carefully at the impact of methods which we choose on treatment. Thus, we must look at the methods of reduction and their mechanical and biological consequence. Here we see a high-velocity proximal tibial fracture with impaction of fragments. Ligamentataxis allows reduction of fragments which have retained their soft tissue attachment, but where you have impaction, ligamentataxis is not a method which we can employ. As you can see the result on the right, the large fragments reduced, fixation was carried out, and as you can see, the impacted fragments remained unreduced. Therefore, intra-articular fractures with impaction require an open reduction. We must elevate the fragments open because indirect reduction is not possible. Cartilage and bone are fundamentally different tissues. They are different in their biological and mechanical properties and principles. As stated, articular cartilage requires anatomic reduction, open reduction, and absolutely stable fixation. The metaphysis and long bone, in distinction, require only a functional reduction. What does that mean? It means restoring length, alignment, and rotation. It does not mean anatomic reduction. And rather than absolute stability, fractures of the diaphysis and metaphysis we can treat with relative stability. Thus, in the proximal tibia, two totally different tissues requiring a totally different approach. What is important in treating articular fractures? We have carried out a major review of the literature, and we embarked on a CT study of over 100 cases of intra-articular proximal tibial fractures from our personal experience. And we attempted to answer the question, what is most important for a good outcome and why? And rather than emphasizing anatomic reduction of the articular surface, it is important to recognize that in treating intra-articular fractures, the first and most important issue is securing joint stability. Joint stability, if the joint remains unstable, the destruction begins immediately. It affects immediately the outcome. Whereas if the joint is reduced and is stable, but articular incongruity remains, the effect of the incongruity will express itself months or years later as post-traumatic arthritis, but the function of the joint will be preserved. Thus, we have to recognize that we're dealing with two different issues: joint stability and joint congruity. In the early teaching of the 1960s, we emphasized anatomic reduction of the articular surface in order to achieve joint congruity, to optimize the surface, and to reduce the stress. These fundamental principles of 1960 remain unchanged. However, the current concept emphasizes joint stability as the first and most important thing to achieve. So, since joint stability is so important, more important than the anatomic reduction of the articular surface, allow me to examine the factors which govern joint stability, because that is what we must recognize and must deal with first and foremost. The first is the restoration of the anatomical axis of the limb. Intuitively, we know that if we allow major degree of axial malalignment to persist, that we're not going to succeed. So the first principle is achieve a straight limb. Allow me to deal for a moment with the forces involved in an intra-articular injury. The forces which we are dealing with in trauma are shear, compression, and torsion. The first important thing to recognize is that torsion has no effect on the intra-articular component of a fracture. It directs the fracture pattern in the metaphysis and diaphysis. The intra-articular component is the result of shear and compression. This has major consequences. Allow me to show you the three fundamental morphologies of intra-articular fractures. The first example is shear. Pure shear results in shearing of a split wedge. I'm introducing you to a concept which I will emphasize, a split wedge. Compression leads to impaction of the articular surface. Impaction may, or I should say compression, will lead to articular surface impaction, and if compression exerts itself on the rim, it will result in rim impaction. So when we're dealing with an intra-articular fracture, we must recognize the split wedge, the articular cartilage compression, and we must make certain that we're not dealing with a rim impaction. What do I mean by a split wedge? The shearing element shears a three-dimensional anatomical structure. as illustrated schematically, you see that we have a three-dimensional structure which is covered with articular cartilage on its surface, and it contains part of the metaphysis, and it exits in the metaphysis. The splitting of a wedge disrupts the rim continuity. This is terribly important to recognize. We are dealing with an injury which shears in its principal fracture plane, that is the plane in which the force is acting, an anatomic portion of the articular rim which is displaced or potentially unstable. And here you see from an actual case, prior to reduction, you see the lateral condyle shearing a split wedge. You lose continuity of the rim, and you have a state of instability. This split wedge has a point where if we apply force, it is reduced and we achieve a state of containment of the split wedge, and we regain reduction and stability. This is not reduction of the articular surface. Of course, portion of the articular surface is reduced. But what is most important for you to recognize, that reducing this split wedge restores joint stability. And if the split wedge is not perfectly reduced, instability will persist. Here you see this schematically demonstrated. I've posed this question. I have 3 different intra-articular fractures. The first, you have a split wedge. The second is you have impaction of the rim. And the third, you have impaction of the articular surface. Are these the same when it comes to joint stability? The impaction of the articular surface alone does not result in loss of the continuity of the rim, and unless the impaction is of the whole articular surface, the joint retains stability. And from the first time that I published my classification, I emphasized that we operate on intra-articular fractures to regain joint stability. And the first that we must determine is whether the joint is unstable, and if so, is it a split wedge which is contributing to the instability, or is it impaction of the rim? Thus, successful surgery of an intra-articular fracture demands the restoration first and foremost of joint stability, which means reduction of the split wedge or reduction of the crushed rim. Anatomical reduction of the articular surface is important, of course, for the healing and long-term survival of the joint. Long-term survival of the joint. If you fail to correct the instability. If you fail to correct and reduce the split wedge, the joint remains unstable and failure is from the very beginning. This is terribly important to recognize that we are dealing with two completely different aspects. One is the articular surface, and the other is the element which restores joint stability. Joint stability depends on the rim continuity. Rim continuity, gentlemen. A shearing force interrupts the continuity and results in a split wedge. The displacement of the split wedge, which we recognize, causes the instability. And there is displacement, or in the undisplaced split wedge, there is the potential for instability. And therefore, we must restore stability by reducing the split wedge or the impaction of the split of the rim, which, if you look at it anatomically, is a split wedge. We provide containment. By what means? By buttressing the split wedge. In other words, providing pressure, as it was illustrated with the thumb. There is one point where if you apply pressure, the split wedge will reduce anatomically. So please note the difference between continuity and containment. I am introducing terms which are important. They have a specific meaning. And here you see that if you have crushing of the rim, rather than using a vertical buttress plate, we require something akin to a hoop on a barrel, a horizontally flexible plate, so-called hoop plate, to restore stability. And in this one case, you see both principles illustrated. The buttressing, maintaining the split wedge, and the hoop plate, the horizontal plate, supporting the crushed cortex of the crushed rim. Of course, the use of these implants depends on the architecture of the fracture. You may have just a crushed rim or a split wedge or both. Now, I'm posing the question, how do we assess the rim discontinuity? Imaging is the only method available to us. And I would put to you the fact that achieving a CT on admission of a displaced intra-articular fracture is to achieve an image of many pieces, and we really have no idea where they belong or what they represent. So before we do the definitive CT to find the injury, we must provisionally achieve provisional reduction. Now, when we do a CT, we can easily recognize the principal fracture plane, the plane in which the split wedge is sheared. We are able to recognize the split wedge. we know that we must achieve reduction of the split wedge to restore continuity of the rim, and we must provide containment by buttressing. And the answer posed many times, what is the ideal placement of the buttress plate? The placement of the buttress plate must be parallel to the principal fracture plane. This directs the position of the plate, and this will direct the positioning of the patient, and it will direct the surgical approach. So these basic facts are important from the very beginning in the decision making. And please recognize that I'm speaking of two very different things. I'm talking about stability of the joint and not stability of the shaft. And in dealing with an intra-articular fracture that has the diaphyseal extension, we must not deal only with the joint, but we must also recognize that we're dealing with a long bone, which has two columns, and we must achieve support and stability for the columns. So we are dealing with the injury to the joint itself and the injury to the metaphysis and diaphysis. These are the fundamental principles, and I'm emphasizing principles because decision making is to recognize the principles that represent the issues that we must reverse in order to achieve success. The last 60 years have seen an enormous progress in imaging. In the early days of the AO, all that we had available were plain X-rays. We could do an AP, a lateral. We did 2 oblique projections in order to gain some three-dimensional concept of the injury. We had early tomography was only in 2 planes. The arrival of the CT has allowed us to achieve three-dimensional representation in the coronal plane, in the axial plane, and in the sagittal plane. By software manipulation, we can also restore the three-dimensional surface of the bone. And recently, relatively recently, the introduction of the MRI has allowed us to study the associated soft tissue injury, and recognizing the mechanism of the soft tissue injury allows us to reconstruct the forces involved and what we are dealing with. The value of the 3-plane reconstruction is enormous. We see the axial cut, the sagittal cut, and the coronal plane, and this gives us a 3-dimensional representation of the injury. The surface reconstruction gives us a better appreciation. And thus, we must recognize that today, a complex intra-articular fracture requires, of course, on admission, a plain X-ray. After provisional reduction, a CT, and an MRI. The MRI is to recognize the associated soft tissue injury. The CT allows us to recognize the principal fracture plane, the position of the joint depression, the condition of the containing cortex. In other words, is the rim crushed or is the rim intact? There is a tremendous amount of information that we are able to gain from the three-dimensional representation of the injury. And in pre-operative planning, note the importance of the three-dimensional recognition. Here we see a type 2 tibial plateau fracture, but the injury is to the posterolateral rim, which has been crushed, and a surgical approach from the front, the most common approach to these injuries, would expose an intact bone, and you would have no means of dealing with the injury. So the three-dimensional recognition is terribly important in preoperative planning, which first and foremost will tell us the positioning of the patient and the surgical approach which we will have to choose. Failure to plan is really planning to fail. Preoperative planning establishes the diagnosis, the location, and the morphology. It directs the surgical approach, as I have emphasized, the positioning of the patient. It allows us to recognize the fracture anatomy and allows us to deduce the type of reconstruction. There are other related issues that I will touch upon very briefly. The question of bone grafting. Yes, in the early days, we taught autogenous cancellous bone because we did not have the substitutes which are available today. Please recognize we bone graft the defect of the metaphysis, not to achieve healing. Healing will occur without the bone graft. The bone graft is used to provide support for the articular surface. The principle of grafting, very common today, but allow me to emphasize that in angular stability, which is used most often in dealing with these injuries today, you introduce a screw which is rigid and which will lead to destruction of the overlying articular cartilage if it is introduced too close to the articular cartilage. You must leave at least 8 to 10 millimeters to allow some flexibility. Bone is flexible. There are other issues which are terribly important. The primary repair of the collateral ligaments, the restoration of the torn meniscus rather than its excision, the recognition of the cruciate ligament injury, and recognizing that primary reconstruction is not the way to deal with this. Reconstruct peripherally, achieve peripheral ligamentous stability, axial stability delayed, and recognize the associated soft tissue injuries, not only to deduce the mechanism of injury, but to recognize that they require us to deal with them, such as the posterolateral complex, which is commonly involved. Articular reconstruction today, yes, we use minimally invasive with C-arm guidance, but it is complex, difficult injury which demands a number of intraoperative aids in order to be successful. Articular cartilage and motion. If we carry out excellent reconstruction, but we do not begin early mobilization, there will be stiffness due to soft tissue scarring and joint scarring. Joint requires motion for nutrition of the articular cartilage. Surgery with immobilization results in the greatest degree of stiffness. We must achieve stability of the rim, stability of the joint. We provide that with appropriate stable internal fixation, and we must begin early motion. Now the question of weight bearing. Recognize that the metaphysis unites rapidly. Why are we delaying loading? Because of the articular cartilage. The articular cartilage requires time for regeneration before you begin loading. Early motion is not early weight bearing. In complex fractures, we wait at least 12 weeks before we begin axial loading of the joint. Thus, to summarize, the important principles which I have emphasized is the first is the severity of the injury. Are we dealing with low or high velocity? The importance of waiting means provisional immobilization in a high velocity injury. We need to maintain length, and we use an external fixator rather than a plaster splint is to maintain length. Traction if you do not have an external fixator. Once we achieve provisional reduction, we then must carry out the important imaging, CT and MRI, to determine the bone morphology and the soft tissue morphology, the injuries. Determine the type of rim discontinuity. Are we dealing with a split wedge or a rim crush? If we suspect a vascular injury, an early CT angio. I emphasize again, MRI is important to recognize the associated soft tissue injury. Next comes the timing of the definitive intervention. Most important, delay and allow the soft tissues to heal to a degree where they will withstand now the insult of the surgical intervention. Plan carefully the position of the patient and the exposure, directed by what you have to do in order to restore joint stability. Remember the peripheral ligament stability. Do not rely on the healing of a collateral ligament, which will occur with a lot of fibrous tissue and will not restore the stability necessary for perfect joint function. Determine how to achieve column stability. Two different issues to deal with, the joint and the diaphysis. An early functional return is important. By that I mean motion to achieve articular cartilage healing, and we delay weight bearing. And remember that the currently popular and available angular stable plates are only a means of mechanical stability. To some degree, they affect the biology of fracture union. They are not a magic. They are tremendously helpful, They allow us to deal with osteoporotic fractures, which are becoming more and more common, but they do not change the biology of fracture union. Thank you very much for your attention, gentlemen. And I emphasize, rather than having dealt with what do you do for type 1, type 2, type 3, 4, 5, 6, I have dealt with principles. Because if you remember the principles, you will make decisions based on facts, and you will achieve success. Thank you very much for your attention.
Thank you.
Thanks, Professor SCHATZKER. Do the panelists have any questions to Professor SCHATZKER?
Can I? Good evening, SCHATZKER Shetty. Good evening. Nice to have you with us.
Nice to see you. Good evening.
Very, very nice to see you after a long time. Thank you very much. No, I have a question. You really mentioned about the importance of shear and the compression forces acting. It's all right if it is just split and the articular cartilage is just opened and you really reduce anatomically. But sometimes in very, very high velocity injuries, the articular cartilage is really crushed in between. So especially if it is the two column, or even in some of the split fractures, it depends on the velocity and the shear and the compression force. What do you do for that if there is more than 2 millimeters of crushing, where even when you really compress it, it can cause more harm than good?
Well, what I am trying to emphasize, that the most important thing is to restore rim continuity and rim stability. If you reduce the split wedge, and I recognize the problem that you're alluding to.
Yeah.
There are times the articular cartilage is broken into so many pieces that they almost fall out when we open the joint.
Yes.
And the question is, well, what do we do with that?
Yes.
I'm not trying to state that an attempt of articular cartilage reduction is not important. But what is important is the restoration of the split wedge to its anatomic position. If you fail to do that, you will fail from the very beginning. The joint will be unstable, and the patient will not do well from the very beginning. The articular surface is important, of course, in the long run.
Yes.
But it expresses itself late, months or years later, by post-traumatic arthritis.
Yes.
And yes, there are situations where you cannot achieve a decent reduction of the articular surface. And I have no magic to offer. Yes.
Is there a possibility of bone marrow aspiration or any of the stem cell therapy with an arthroscopy if there is an opening there of the articular cartilage? Is there a possibility? Some of the papers have come with the articular cartilage. You put in bone marrow aspiration and see that it is filled up. The gap is there with the crushed.
So we are dealing with two things that we have to recognize. Reducing with arthroscopic control, aiming to achieve reduction of the articular surface. If you do not achieve rim continuity and rim stability, you will have failure, guaranteed failure. Remember, much of the articular cartilage is covered by the meniscus.
That's true.
And if you don't achieve rim continuity and stability, dealing just with the articular cartilage will result in failure. This is the point that I'm trying to emphasize. In the studies that I have carried out with my colleague, Maurizio Cuori, we have recognized that the most important element is to recognize the rim discontinuity and instability. If you don't achieve joint stability, morphological agents like plasma platelet concentrate is not going to help. I'm not suggesting that it has no influence on the articular cartilage, but the first and most important thing to do is to achieve a stable joint.
Not able to connect.
Thank you.
If I can talk. There is a decent amount
Tanna sir, you want to ask?
Huh?
Tanna sir, do you want to ask any question?
Yeah, I want to just give a little point of view. To
Tell me.
Dr. Santaram asked about if it is, as very rightly Dr. SCHATZKER mentioned, the articular cartilage is, since it has been very badly shattered, you rim, okay, whatever the anatomical reduction you have done, axis correction which you have done. And today, there are a few workers who go down and do the transplant of the chondrocyte. So after about 6 months, when the healing has occurred and everything has occurred, and there is a small defect which remains into the hyaline cartilage, they go down and do the transplant of the chondrocytes, which way we are aware of it, and they have reported a fairly decent result onto the situation. So that this is obviously it is being done for the younger people. So in a younger people, you can go ahead and do a chondrocyte transplant after the whole fracture and everything is done,
Yes, sir.
in order to avoid an early osteoarthritis. Yes, sir.
Dr. Sharath here, Professor SCHATZKER.
I would put it to you that dealing with a negative defect, if the joint is stable, that joint is not going to go on to develop post-traumatic arthritis, and you're not going to salvage it by dealing just with a small negative defect.
Sir, there is one question. Professor SCHATZKER, there is a question from the audience.
Yes.
He has sent these x-rays and he wants to know how to treat this particular patient. The plain x-rays are apparently normal, that's what he said, but maybe a small crack was seen, and then an MRI scan was done, and the MRI scan shows these cuts.
I'm sorry, I can't see the MRI.
Now you will be able to see.
Well, I would put it
apparently
to you,
an undisplaced fracture on the x-ray, and these are the MRI cuts which do show a fracture in all the planes. This is the
Yes.
suggestion, and that is the x-ray.
but the fracture is undisplaced.
Yeah.
Therefore, what we are dealing with is a potential loss of containment.
Yes.
You have to recognize whether the fracture involves the medial side or the lateral side. If it involves the medial side, it requires surgery, despite the fact that it is undisplaced, because experience has shown that even if we delay weight bearing, there are forces acting on the joint, and such an undisplaced fracture will or may displace and heal in varus as a result. And then you are dealing with a very difficult intra-articular osteotomy to reconstruct. So the recognition, undisplaced, but if medial, it requires early surgery.
Sir, he wants to know what you will do in this case.
It depends very much. If you are telling me that this is an isolated injury, that there are no other complications, that This occurred as a result of a low velocity rather than high velocity, and I am not faced with a serious injury to the soft tissue, which we're not seeing on the MRI. I would provide containment surgically by buttressing this injury.
Okay,
And
sir.
of course, introducing stability of the articular surface, which we achieve by the proper placement of lag screws.
Okay, sir. Dr. Sharath, you wanted to ask some question? Dr. Sharath, you wanted to ask some question?
Yes, Professor SCHATZKER, you mentioned about the importance of ligament injuries and their role on stability of the fracture, and also mentioned about the need of MRI to find out the ligament injuries. Is there a way to find out which cases do need an MRI, or is it mandatory for all high energy injuries to get a MRI done?
We have recognized more and more the importance of an MRI. You know, I began to deal with these when we didn't have a CT, when we didn't have an MRI. And yes, we did achieve success. But the question remained, and remains to this very day, if we have a posterolateral corner injury without an associated fracture, we deal with the posterolateral corner injury because we recognize that leaving it, yes, it will heal, but it will not be anatomic, and we're not going to achieve optimal restoration of function. So why don't we pay attention to the posterolateral corner, which is involved in many tibial plateau fractures? What I'm trying to say is recognize the injuries and deal with each patient on the merit involved. I recognize that not everyone has the image modalities available, but I'm stating principles for the ideal situation where they are available, and this is what optimally needs to be done. So to answer your question, the simple type 1, 2, and 3 likely do not require an MRI, but when you're dealing with complex, the type 4, 5, and 6, yes, an MRI ideally should be done. And in stages, as I said, an X-ray, provisional reduction, restore length, alignment, axial rotation as much as possible, stabilize with an external fixator, then do the CT, and if you recognize what you're dealing with and you say, yes, potentially this is a complex injury, there are likely important associated ligamentous injuries, then do the MRI as well.
Thank you,
There is
sir.
a question from Dr. Puneet from the audience. Repairing the ligament should be done at what time? Early or after fracture healing?
Early.
Yes.
Not cruciate ligaments. Please, gentlemen, recognize that we have in a knee joint peripheral stability and axial stability. Collateral ligaments repair early. Posterolateral corner injury, repair early. Cruciate ligaments, do not try to do a substitution at the time of injury. You will end up with a completely stiff joint. Cruciate ligaments, after the fracture has healed, if there is still instability, now the result of cruciate insufficiency, the joint is fully rehabilitated. Now is the time to deal with the cruciate injury.
Yeah, another question from Dr. Sunil Kulkarni. We don't need any bone graft nor any substitutes to support the articular surface in young patients. In old patients, it is okay. Once a rough plate is fixed, then there is no need to put anything. What is your opinion?
Answer.
As I have attempted to point out, we do not need bone graft in order for the fracture to heal. The fracture will heal. The bone graft is used to fill the defect in the metaphysis, which results when we elevate the impacted fragments. There is always a defect resulting in the cancellous bone, and that we fill. We used to fill it with cancellous bone. Today, we often resort to a bone substitute. It is a filler. We also support, when possible, the articular fragments with the rafting principle. And if we're going to use a K-wire, which we leave permanently, we use a very thin and flexible K-wire. It will maintain position of the fragment, but it will not lead to rigid fixation. Because articular cartilage, the joint nutrition is the result of slight motion, which allows the pumping mechanism of nutritional diffusion to nourish the articular cartilage.
Sir, there are many more questions. We will take them a little later. I would suggest, I would request you to continue with your next talk. Is that all right, sir?
Yes, of course.
Yeah.
I have to exit from this.
Professor, you can start sharing your screen again. You can go for the share screen option on the bottom.
I have to bring up the lecture.
Yeah.
Yes, Professor. You can direct him.
He's looking for Prof, do you have a problem? You need some help?
No, he's not.
He's trying. No, he's not.
He's not.
Professor, can you click on the share screen button?
Yes.
We are unable to see your screen. Try again.
Just a moment. I can't get to the lecture. I'm sorry.
You can reload it. We can take some other questions.
I will take Professor comments.
Just ask him. Professor, can you go with the next talk and come back to you? Okay.
I'm trying to, and I'm not.
We can see your screen, Prof.
We can see your screen.
You can stop. You can close this presentation and go to your desktop.
Sure, you have to give me a moment, please.
Yeah, sure, Prof. We'll wait.
Join back.
Sponsor me. Professor, I think you need to click on the share screen button again.
Just a moment.
Want to make a video call?
Just give me a moment, please.
Sure, Professor. Just want some time. Yes, Professor, you can go for the full screen slide. Yeah, now we can see, Prof. We can proceed.
Very good. Thank you. We will proceed now to the second talk, which deals with the extension of my original classification to a three-dimensional classification. In 1974, I published the Tibial Plateau fracture classification, which was based on a two-dimensional representation of fracture patterns. The principle of the classification, the organization, is according to the essence. By the essence, I mean, what are the important elements? The age of the patient, the bone quality, the morphologic architecture of the fracture, the morphology, the energy. So types 1, 2, and 3 are fractures, and 4, 5, and 6 were fracture dislocations. I recognized early on the importance of the energy involved, and I emphasized early that the indication for surgery was joint instability, and I emphasize again instability. The imaging modalities available in 1974, as I outlined before, was plain radiography. It is important today, as it was then, an AP, a lateral, and an oblique, preferably in two planes, is as important today in order to recognize, and this is what we take in the emergency, not a CT, not an X-ray, to recognize, so to speak, the forest, and then we will deal with the individual trees. We had two-plane tomography. That is all that was available. And the result was that most fracture morphology that we appreciated was anterior-posterior plane. It was not until the advent of the CT that fractures in the coronal plane became well recognized. And thus, we missed many elements, did not appreciate them. My colleague, Maurizio Furi, with whom I have been collaborating since 2008, he was then working in Ribeirão Preto in Brazil. He said to me, Joe, wouldn't it be nice if we had some ways of being able to state precisely the three-dimensional orientation of the fracture? I recognized that it was something that I was not able to answer, and therefore we embarked on a the study first to revisit my classification 4 decades after its description. We then examined each fracture type in the light of information made available by the CT scan, which comprised the standard and essential tool in assessing any intra-articular fracture. We incorporated this new information made available by the CT and looked at the essence of the 6 fracture types. The CT allowed a 3-dimensional representation of the architecture, and we embarked on finding a means and ways of extending the classification in 3 dimension. Why the 3-dimensional imaging? Well, it's the basic imaging for all intra-articular fractures. It provides a new standard of understanding of intra-articular fractures. It greatly improves the intra and inter-observer reliability and reproducibility. And as I have emphasized, the MRI information we recognize recently is very important to demonstrate the soft tissue injury present in these injuries. It allows us to understand much better the mechanism of injury. And all these modalities allows us to gain a complete understanding of the complexity of the injury. We also made the observation that with the beginning of this century, more and more publications have been emphasizing the 3-dimensional information that is important in the diagnosis, which means the decision-making, which leads to the correct surgical approaches and methods of fixation. My good friend from Shanghai, Luo Confeng, from number 6 hospital, proposed a 3-column concept, with the 3rd column being all posterior fractures, best appreciated, of course, in the CT study. However, he did not differentiate, and I emphasize the posterior medial and posterior lateral fractures. He lumped them together. Chang proposed division into 4 quadrants for greater clarity when dealing with high-velocity bicondylar injuries. The results of our CT study, which I undertook with Professor Khoury, allowed us to reach certain important decisions and establish new principles. Professor Khoury proposed the virtual equator of the proximal tibia. This is virtual. It runs from the anterior tubercle of the head of the fibula to the posterior edge of the superficial medial collateral ligament. These are features easily discernible on the axial cut, and this divides the tibia into an anterior and posterior surface, which are not equal. This is not an equator. This is a virtual equator, but not a division. Here you see it represented schematically. And now if we draw a line from the tibial tubercle from its medial edge to the foot plate of the posterior cruciate, we are able to divide the proximal tibia into 4 quadrants: the anteromedial and the posteromedial quadrant, and the anterolateral and posterolateral quadrant. But we now have a means of having a virtual equator, which allows us an anatomic division of the proximal tibia into 4 quadrants. I would put to you that the surgical approach to these quadrants is defined by the presence of collateral ligaments, the medial and the lateral, which are elements that make an anterior approach insufficient in order to reach a posterior quadrant. And that is important to recognize in speaking of the 4 quadrants. The most important element in the treatment of intra-articular fractures, as I have emphasized, is the restoration of stability. And we must find the key element responsible for joint stability. I emphasized in my previous talk the mechanism of articular fracture, shear and compression. Torsion deals with the metaphysis and diaphysis. And I emphasized the importance of the joint rim in preserving joint stability. And I did emphasize for you the split wedge as the key to the loss of rim continuity. Now, why am I emphasizing this? There are classifications today which divide the tibial plateau into 10 segments. That may localize a fracture, but it has no meaning because it doesn't tell you whether that particular fracture, what is its influence. I have emphasized the recognition of the split wedge. Once we recognize the principal fracture plane on an axial cut and the split wedge, we are able to determine whether the split wedge is anterior to the virtual equator or whether it is posterior. And in this schematic representation, this is a type 1 tibial plateau fracture. It is lateral. It is anterior. It has no posterior component. So I'm able to recognize what is important, the split wedge, because I must restore joint stability. And it tells me exactly where the split wedge happens to be. Now, we have a fracture of the medial plateau, a type 4. And in the original classification, which I published, I emphasized the fracture of the medial tibial plateau, but I was unable to localize that in 3 dimensions. I was unable to tell you whether it is anterior to the equator or whether it is posterior to the virtual equator. This is a medial posterior. So it is a type 4 posterior. That tells you immediately how you will position the patient, and it will tell you immediately the surgical approach. remember the concept of split wedge reduction and providing containment. This tells you, as a surgeon, where you will need to position the buttress plate. And that, of course, tells you how to carry out your surgical approach. Now, schematically represented is what we would call a comminuted fracture of the lateral tibial plateau. Before this extension of my classification, all I was able to tell you is that you're dealing with a type 2 fracture of the tibial plateau. But today, I'm able to tell you that there is an anterior split wedge and there is a posterior split wedge. And my surgical approach will have to be such that I am going to be able to buttress, provide containment for both the anterior as well as the posterior split wedge. Because if I don't, I will leave potential instability or immediate instability. Now, apply this concept to a bicondylar fracture. We have a fracture which involves the medial plateau, and we have a fracture which involves the lateral plateau. Yes, the classification tells you that it is a type 6. But beyond that, I could tell you that yes, there is a comminuted fracture of the lateral plateau, and there is a fracture of the medial plateau, but I was unable to localize this for you in 3 dimensions. Now, if I write down this is a type 6, medial, posterior, lateral, anterior, and posterior. This has tremendous meaning because you now can deduce which surgical approach you are going to use and how are you going to position the patient in order to deal with the posterior element and the anterior element. At the same time, or you will do 2 completely separate approaches. But you know the problem. I now have a means of telling you the elements of the injury. Let's look at a clinical example. You see the X-ray, you see the CT cuts, and you see the schematic representation. This is the classic type 2 anterior. This is a simple problem. This is a type 3. The impaction of the articular surface is posterior. I'm not going to deal with, yes, are we going to do this arthroscopically? What are the indications for surgery? In the extension of the classification, I'm simply trying to tell you how the classification has been extended to be able to tell the surgeon the key element and where it is in 3 dimensions. So this is a type 3 posterior. Now we have a comminuted fracture of the lateral tibial plateau, a type 2. But today, with the extension, we see that we have 2 elements to deal with. We have an anterior and we have a posterior. If you deal with this injury by reducing only the anterior split wedge, and you leave the posterior split wedge unreduced and unstable, this knee will never do well. So what are we trying to accomplish? Well, let us look at a couple of examples. This is what, unfortunately, we continue to see. This is a 48-year-old perfectly healthy man who presented with a type 6 tibial plateau fracture. Here we see the patient initially in traction. Yes, this will maintain length, but despite the traction, you see the impacted articular surface. The surgeon opened the fracture. It was beyond his surgical ability. So he had the patient in traction, so he added continuous passive motion. And at 6 months, this was the surgical result. This is what it looked like on X-ray, and this is what it looked like clinically. I think all of you recognize the horrible failure of treatment. This patient had surgery, but this patient did not do well. Why did he not do well? If you look carefully at the X-ray on the right side, you see that there is a posterior medial wedge. This is a type 6 with a posterior medial component, which was unrecognized and untreated. And if you look at this carefully, you will see that the knee joint at 7 months after surgery continues to be subluxed because the medial condyle follows the unstable fragment of the tibial plateau. This is after corrective surgery, 7.5 years follow-up, perfect joint. So what have we accomplished? Well, we have established new anatomical landmarks for the proximal tibia. If you will try to tell someone where the injury is, today you're going to be able to, using our system, localize it in 3 dimensions. We have defined the virtual equator, which divides the proximal tibia, and with the line from the tibial tubercle to the footplate of the posterior cruciate into a medial anterior, medial posterior, lateral anterior, and lateral posterior. And I have emphasized for you the principal fracture plane and the split wedge. It is the split wedge which is the key to joint stability. And we have defined the split wedge and how to determine its anatomical orientation. Is it anterior or is it posterior to the equator? And these letters define the principal fracture plane: anterior, 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 posterior, posterior. It tells you the instability. If you define the split wedge, the loss of rim continuity, and the loss of containment, the portion of the rim with the attached metaphysis which is displaced and which must be reduced in order to restore rim continuity and joint stability. The outcome depends on achieving joint stability, congruity, and a return of the anatomical axis to normal. We continue to emphasize the three-dimensional imaging, the CT and the MRI, as essential preoperative studies, essential for proper preoperative planning when dealing with complex injuries, particularly in the coronal plane, where there is a posterior element difficult to expose and difficult to deal with. Achieving surgically joint stability and congruity depends on the exact identification and three-dimensional localization of the morphological elements of the fracture, such as its fracture plane and the location of the wedges responsible for joint instability. And I emphasize here, while recognizing the anatomical limitations provided by the collateral ligaments in the surgical approaches to the four different quadrants. Preoperative planning will assure proper patient position and the choice of the proper surgical approach to achieve reduction and stable fixation by proper placement of the necessary implants. Why is this important? These, gentlemen, are the prerequisites to achieve the best outcome possible when dealing with complex intra-articular injuries. The aid is the three-dimensional extension of the original classification while retaining the six principal types. We are providing an accurate three-dimensional localization of the fracture morphology and provide a method of accurate notation. We have greatly improved the accuracy of the new extended classification, which we hope will greatly enhance surgical outcomes and greatly enhance clinical research and multi-center studies, because it will allow us to speak with the same language and know exactly the location of the fracture, the location of the fragment important for joint stability, and how to deal with it. I thank you, gentlemen, for your attention. It has been a pleasure for me to share these important observations, recent, but they have greatly advanced our comprehension and understanding of these complex injuries and how to deal with them. And the extension of the six principal types has retained the classification, but it has allowed us now to state the classification in three dimensions. So if I tell you that this is a type 2, anterior and posterior, it is far more than stating this is a comminuted lateral tibial plateau fracture. That told you it was going to be difficult, but it didn't give you the essence, what is important. If I tell you that this is a type 6, medial posterior, lateral anterior and posterior, you can immediately visualize the problem in three dimensions. Thank you again for your attention. It has been a pleasure to present this work.
Thank you.
Prof. SCHATZKER, thank you very much. What we intend to do is we would request Professor Tanna to take on and present his talk, and then maybe some questions will come, and then we will open it to the faculty.
Very good. Thank you.
Yes, Professor Tanna, sir, can you please take over? Professor Tanna, sir?
He's muted.
He is muted.
He is muted. Yeah.
I'm taking it over.
Yeah, thank you, sir.
Yes.
It's taking while taking it over. Hey, Ram, Ustad hai Ram.
Can you see my presentation?
Yes.
You've seen?
Yes,
Can
sir.
you see this?
Yeah, sir.
Yes, sir. Yes, sir.
Yeah, now
See, I'm going to talk about my journey through the proximal tibia. I joined medical as a house surgeon in 1961 somewhere, 60, 61. And that time we used to quote Professor SCHATZKER and otherwise. Now here is the first case which I will just discuss. Here is the case. If I can ask any of the faculty, this is the fracture of the fibula here, as you can see. And the lady had quite a lot of skin abrasions and all. I will proceed for this case. As you can see, here is the one pre-operatively. Anybody wants to comment?
Yeah, can I?
Yes, please.
You'll have to get a CT and an MRI both to understand the fracture better because there is an avulsion of the
Avulsion of the fibula. Yes, you are right. So here it is. So here I got the CT done. As you can see, the CT will come just now. Now here is the CT. And you can see there, whatever is not seen in the X-ray, there is a depression which is seen in the anterior part of the tibia. There you can see that. And the other thing is the fibula, which is seen very, very much. And here was the MRI, where we saw the ligaments which were affected, but we also saw the lateral ligament is affected and is injured. So once there is the fibula which was going on, first and the foremost we did was the open of the fibula, put it down with the 2K wires and the tension band, and we had to completely suture up the posterior cortex, posterior corner of the whole ligament, whole complex. And here you can see the bone. This is pre-operatively. So we went down, made a window, elevated it, and put it there. This is the one which is elevating it, and you can see the whole thing has been elevated. And then once it has been elevated, the whole thing has been put in with the small raft screw, that is all what was required. And as you can see there is the hydroxyapatite which has been put there, and this is the tension band of the things. And at the end of the surgery, you can see this is the lateral surgery and the medial surgery. At the end of the surgery, the fracture became completely stable, and even the ligament complex and everything was stable. So this is the thing what we can do it now. But in those days, I'm talking about now in earlier days, this is the CT scan after the operation. As you can see, the whole thing has been elevated. There is the anterior part into the ACL area. There is a small amount of avulsion which is there. And this is what was ultimately the end result of this surgery. And you can see this has been very well appreciated. The articular surface has been restored. And the whole thing has now come back to normal. Now, this was a 17-year-old girl, so I didn't want to leave anything away. And that's the reason why this is the one which was done it, and this is the way everything has been. You can see that this is the screw, and here is with the elevation which has been done of the ligament. This is where the fibula has been put back. And you can see there is a small part of the piece of bone which was there. So this is what we do it today. But now what we did in past, in 60s what we did, this is the conservative treatment. Only with the tibial fraction, this is how it used to be treated. And you can see the fracture is held up. And then we did the CT scan later on, And you can see that this is the CT scan. This is already many years afterwards. You can see it over here, and the patient is walking about beautifully. You can see this patient is walking about. He has a good range of movement, and he is walking about. Now, this is all this is the 5 months which was there, and I have seen the patient after about 2-3 months, 2-3 years afterwards also, and the patient is comfortable. But whether he is going to remain comfortable, and we know it very well that this joint is not going to last for a longer time. So immediate results, range of movement and everything is good. That is not the issue. Here is the second one, 8 years after a calcaneal fracture. The fracture is, the patient is walking about. In spite of so much of a depression, everything is, he has been able to walk about. But the purpose of surgery is to maintain a pain-free, good movement for life. This is the one which is not going to remain for life. And that's the reason the first case which I showed you, even there was a minor depression, and since there was a posterolateral instability, we went ahead and corrected the whole thing completely. This is what we used to treat in past, and this is where the CT scan, as we all know, as we have heard just now, Dr. SCHATZKER, has changed the whole picture of the surgery. Now, the medial side is a separate plate. It was not known. So I think here then there is the MIPO, people took it over. And then there is the lateral plate which we did it, and the surgeon did this MIPO onto the medial side without really going posterior medial. This is what it created a problem. Surgeons have been trained to put on the lateral plate for a depressed fracture, and because of the fear of the wound healing, do not open up the medial side. And that was the pulpitinous fixation tried to do it, and it never worked. And so we put in this X-fix, as earlier mentioned, either it's a medial side or the lateral side. So the lateral side plate and a medial side X-fix, this was being done. We all know it very well. But this is not the treatment which we can ever do it just now. Because now we know the medial is not medial, anterior medial, posterior medial and everything. And now I'll talk about if we did the mistake or if the things did not become all right, what can we go ahead? Now here is the one where the fracture was treated only by one plate here, and so it collapsed. So this is mandatory. They do not accept the deformity, correct it early. Unfortunately, our own patient having this deformity may not get the benefit of correction unless he sees somebody else. But if we get this sort of a problem, the varus deformity, the surgeon, operating surgeon, tends to ignore this because he doesn't want to accept a failure. While if here it is, you go down, correct the deformity, and then you have a much better chance for the joint to survive for a long time. Here is the post-operatively. This is what was the deformity. And as you can see, there is a dense sclerosis. So when you correct this deformity, my observation is that if this is the deformity which you corrected, this is the cora. As you can see, you corrected that cora, and I have put in the plate after doing a fibular osteotomy. But this is the one. At times, osteotomy through the sclerotic area may delay the healing. I always graft it locally, autograft, because I feel that unless this area is being decorticated and you put in the graft there, and then this is the reason I feel ordinarily you do not need the graft, but if there is a dense sclerosis, then you need the graft in order to be 100% sure that the healing is going to occur. Now here are these are the deformities which occurs, which we have seen it again and again, but do not accept it. Go ahead, see the deformity, find out the cora, and it is the only way in which you can really do it is to correct it. So all these deformities should be corrected early. As you can see, the articular surface is fairly well maintained, and if you correct the deformity and correct the axis, then it's going to be a much easier thing for the patient to carry on for a much longer time. Unfortunately, as I said again and again, I will say, our own patient, we tend not to do it, while somebody else's patient, we always go ahead and correct it. Here, as you can see, here was the cora, here was the cora as we found it out. So it was done, the fibular osteotomy and the correction, and that way we went around, and ultimately the whole thing ends up. Now here, all this is the one which I advise correction for this. I saw fairly early in about 8 weeks time. I advise early, but unfortunately, as you can see, being a MIPO, this is joint depression has remained because the surgeon has only tried to do this. He hasn't gone on to the medial side and posterior-medial side to put in a buttress as you and me will do it today. Now, this is very difficult to do it. Now, here, as you can see, the surgeon has done all Nipple surgeries, and the person is walking about, moving about, has a decent range of movement, but still he has no pain initially. But this is not going to last long time. Now, here it is, Nipple surgery had taken over earlier with this sort of a problem which was there. All this is what was seen in the X-ray. While surgeon did the plate, did the medial things, and you can see this posterior medial part, he only is trying to do a bit more. This doesn't work. This is the one which will create a lot of problems. This is the one which is not desirable. He did closed leg screw without reduction of the posterior medial fragment, and this is the one which creates the problem. And again, why would a sane orthopedic surgeon do surgery like this? He has done this. It is only because, or like the next one, he did the same surgery, and this is the posterior condyle, and it's the same one. This is the one which is the range of movement and everything. And you can see this is the Nipple surgery he tried to execute that. No posterior medial incision. This is the small plate and everything. No orthopedic surgeon will do a surgery like this on his own, because it is not described in the textbooks or any journals that you can treat 4-part proximal tibia by Hyaline or by Nipple. He only heard somebody in the meeting and he got inspired by the speaker. Do not get hypnotized by we, the faculty. Do not believe whatever I say all the time. Is my view, not necessarily the right view. We all the faculty are called upon for our distinct opinion. And like if Shiva opposes humerus nailing, why will he be called to the meeting to give a talk on a humerus nailing? That's the reason he has to go on talking about the humerus nailing. I say this because I like Shiva, but may not agree on this view completely, and I will not oppose in all the meetings we attend. So do not trust us fully, because in the meeting people see this. At times some of the speakers talk about it, and this is what happens. Now here you can see the Nipple, typical Nipple. The surgeon had this sort of a fracture. Here was the fracture. You can see it is a lateral side. So he did this screw fixation laterally, and this is what happened afterwards. This was immediately, and you can see the CT scan. He has not done the screw fixation which you desired to be done exactly like this. As a matter of fact, he has done the screw fixation onto the edge of the fragment, and it is shattered down. As you can see, it is shattered down. And so ultimately, and he has put in the screw, the fracture is posterior. He has put in the screw there. It needed a buttress plate. So this is exactly the one where the people used to treat. And I find that unless and until you have very rightly mentioned by Dr. SCHATZKER, you have the CT view and go down exactly wherever is needed to buttress it, it is not going to work. In the hindsight, leave alone could have been better than this screw. Open surgery would not have allowed this mishap. Now here is the surgery. The surgeon did this Nipple surgeries, 3, 4, 5 screws, and this is the one ultimately it needed to be corrected. So I feel that if ever you still get a deformity after this sort of a surgery, locking plate with the grafting after correcting the upper extension and the axis correction, this is the one which is the treatment of choice, and it has to be done. Now I'll come to those still more difficult fracture. Here was the fracture. This was the CT scan, and surgeon got really scared, and he did this K-wire, these small screws and the tibial traction. This is not functional, it needs correction. 9 months, it is difficult, but if not immediate then for the future TKR, this needs to be done. And you can see here was the range of movement. This was the range of movement. This was the range of movement. This was the flexion deformity. This was the deformity, 9 months, unstable, unable to walk. And so now you plan the surgery. So you plan the surgery, it is the anterior translation of the tibial shaft, flexion at the tibia, rotation of the tibia. So you see the cora. This is where you need the deformity, 7 centimeters below. So this is the first thing. Now, so you've done this, you've done this, so you will now correct the first is the axis. So now you corrected the axis. Now posteriorly, You can see that this is what is the posterior. So you will have to correct that. So you put it anteriorly and put in the screw posterior to anterior and correct it. So now all what you've done is you've done the tracing, you found out exactly what needs to be done. So in AP view, lateral view, you have corrected, and here it is, you know that there is going to be a gap here. So this is the one which will need a grafting, and you have done the plating there. This is the tracing must be done for all corrections. And here you can see it very well. This is what is the tracing done. Here was the one. So it was postulated pre-operatively in the thing that you will have to do the grafting here. This is how it was corrected. This was the maximum correction which we could get. And then we realized that this is the way in which we will be able to do a TKR if at all it is needed. And this is at the end of the surgery. Patient had a range of movement only this much, but this is the one axis was corrected. And in the future, at least if he needs surgery, it can be done. So I feel that no deformity should be left just like that. Here was the surgery. Again, this Aliza Rao took over. And the people started doing Aliza Rao, and Aliza Rao fever set in. Here was, you can see this was a very small fracture. Surgeon did the Aliza Rao, minimally invasive surgery, and it ended up into infection, badly shattered and complete joint which was gone, infection, control of the infection, and then we went down and it needed a fusion to be done because the patient wasn't willing for a knee replacement. What a disaster minimally invasive surgery of Aliza Rao type can do to this patient. Now here is the one which, as I mentioned, 0 to 60 degree range of movement, and you can get this ultimately a good. He was moving about. I had followed this up after this surgery for about 3 years. He was perfectly moving about with this range of movement, and obviously he will need surgery in future. Now here is the fracture. 6 weeks after conserved, pain and difficulty in walking. As you can see, when you do CT scan, there is a depression there, and there is a fracture posterior medially. So now, how do we plan it out? This is what is the fracture is on the medial side. So plan it out. You will have to correct this, open it out, open up the intra-articular osteotomy, correct this deformity, open it up, and then we'll have to do this thing there. So need the space to go this, and MCL comes in the way all the time. So the osteotomize the medial epicondyle and take away the MCL. This is what was done. Epicondylar osteotomy which was done. And once the epicondyle has been removed from this site, then it becomes so easy to go ahead. And this is where it is. They could see the whole thing very well. The intra-articular step here, you can see this is the intra-articular step here, which was corrected, opened up and corrected. And ultimately it was reduced. The whole way intra-articular step was reduced there. And here is the gap which was filled up with the graft. This is how it is. Ultimately, this is the final correction. And epicondylar osteotomy which sticks up with the screw. This they can perfectly all right. But he had a stiffness. So this is what is 2 years later. He had some stiffness. So we went down arthroscopically. It was released. And there is a good range of movement which was achieved after the whole surgery was completed. And as you can see, this fragment which was posterior medial, the plate has been put posterior medial after the intra-articular osteotomy. So once now CT is a must to treat the proximal tibia fracture, we expect complication rate reduce. I do not think so, because we all do not really treat them, because most of the surgeons are not necessarily updated, they are not necessarily trained, and they do not do the complete job all the time. Here was the patient. The surgeon treated only this fracture, as you can see. He went down in medially and treated only this fracture. By the lateral fracture, he didn't treat at all. This is what is the patient. Ultimately, 9 months, he came over. This is an overflowing tibia. The lateral side is not reduced. And he had a patient, had a pain, young girl. So I went down into the situations. I did this. Now, once you go down, there is a fibrocartilage which has been put in onto here. So once you go down to the intra-articular osteotomy, you will be able to demarcate the articular surface here, articular surface there, and whatever is the intra-articular osteotomy we have done, then you will be able to see the two hyaline cartilages, and in between you will see the fibrocartilage. So you remove that fibrocartilage, excise that fibrocartilage, put the hyaline cartilage to hyaline cartilage, and ultimately once you've done that, you hold it up and put in a leg screw. Once you put in the leg screw, and you will be able to get the whole surface reconstructed. This is after 1 year, because everything has not come back. It was perfectly all right, as you can see here. Probably a buttress plate, but I don't think that was the issue. But this was the hyaline cartilage which was damaged. That is the one which has done this situation. But fortunately, patient had an excellent range of movement. Patient had an excellent range of movement, and patient carried on. This is 1 year, and at the moment it is about 5 to 6 years, and she is fine. She comes occasionally with other patients, but I don't know how long it will last. Now here it is, the 27-year-old comes out, pain after 4 months. Any idea? Anything anybody would like to offer?
Kuch drink maybe, coffee maybe, coffee.
Dr. Sharad?
Sir, CT.
Huh?
CT scan.
CT scan, that's right. Here is the CT scan. As you can see, this part is an intra-articular depressed problem here. This is the non-union which has occurred. You can see it very well. And this is the reason why the patient had a pain. But if you see only the plain X-ray, you feel as if everything is fine. You don't need anything to be done. But the CT is really revealing completely, and this is how it was. So I did the CT scan, and as you can see, this area is depressed. This fragment and this fragment have to be together. This is the area which is depressed. You can see it over here in this view. So I went down, did the intra-articular osteotomy. I did the intra-articular osteotomy. I corrected this. I elevated this intra-articular depressed part. Elevated it, and I filled it up. Here it is, I have elevated it, and I filled it up. And here is the graph. But you see, where is the bone here? Actually, what happened, the bone came down here on the table. It fortunately didn't go on the ground, but the whole thing, when we were trying to correct it out, this bone became a separate piece, and it just came down. It came down there, so we put it back. We put it back. Put in the compression there, put it there, put in the compression, and put in the buttress plate. After elevation, this is what has been put in hydroxyapatite, and there is a screw which we have put into raft screw. And well, this is 4 months, perfectly all right. And this is also now about 2 years. I think a few months back I phoned him up during the COVID lockdown. He said it's perfectly all right. This fragment which had gone down probably on the table has gone back there. Up till now, there is nothing has happened. He is functionally perfectly all right. And this is the X-ray which is there. The 33-year-old doctor, male, injury 2-3 months, operated by a local surgeon. And here was the fracture. Posteriorly it is there. So the local surgeon went posteriorly, and on the lateral side, probably he chickened out or whatever it is, he put the posterior plate, and on the lateral side it did nothing. And as you can see, there is a big depression over there. There is incongruity and all. And this is the stage about, I think, 3 months, if I remember. Yeah. About 2 to 3 months, it was after the injury, he came over to me. So I went down, you can see the CT scan. You can see the CT scan, you can see the posterior medial fragment, which is like this. After the operation, these are all the CT pictures with the screws, you can see them. There is a depression there. Still, it has not been corrected. He is just poor chap has put in a plate. Probably he wasn't really trained to do it, or he wasn't really heard much of the things about it. And here he was in AP view, still there was a lot of depression which was there. And at this stage, 3.5 to 4 months by the time I went in, because by the time the patient decides that does it, he was a young man. So I went down, and here it is how it was there. I went down, I His posterior plate was also, I feel it was too below. So I went down from here to, I put in the posterior plate, far too up properly at the buttress. I went on the lateral side, did the lateral osteotomy, removed the screw, lateral osteotomy, kept this bone, corrected this area, whatever best could be done, it was done there because it was too small a piece which remained there. And ultimately, this is what it turned out to be. So the articular surface is not all right. This is the one which I mentioned to you, that though he has an excellent range of movement and everything, but I am not very happy with the radiology. From here to here, he has come in. All this elevation and everything has been done. But this plate has been now put in properly. This is how he is held up now. And he has this excellent range of movement. He has a good range of movement. Patient is happy now. But ultimately, how long it will last is anybody's guess. So all these things, as I said, immediately, whatever is the X-ray, these things are become all right, but not necessarily it will remain all the time. Here was the patient. This was the original X-ray, and surgeon went down and did these 3 screws. 4 months after the fixation works with the painful thing, this is how the CT scan was. And as you can see, this is how the CT scan, there was a depression there. So the only way to go down is to do an intra-articular osteotomy. So I did the intra-articular osteotomy, again excised all this fibrocartilage and put in the 2 articular surfaces together, buttresses with the screws, depressed, then the plate which was depressed, it was grafted in between. 3 months, there is a full range of movement. And this is 10 years follow-up. He has come up with everything, and you can see the picture. And he could squat about, he can move about, he can walk about, and he has done everything. He has an excellent range of movement. This is 10 years now. So I feel that it is absolutely worth it when he had very restricted movement with flexion deformity, and now he has a full range of movement. So this is the 10-year X-ray which is there. But you can see the change of the X-rays occurring. This is I want to observe you. This is what we were talking about, the hyaline cartilage damage. If the hyaline cartilage damage has occurred, we have done the intra-articular osteotomy, tried to correct it. The radiology is not perfect. You can see it here. This is perfect, while this is not perfect. So the patient is walking about and moving about. So I feel these are the ones where some of the workers who talk about it, to go down early and try to do the chondroplasty for this. I have no experience of that, but this is at the 10-year excellent range of movement which is there. This was the last patient I will talk about it. This is how the day 2, I think in India, where you get the patient, you grab the patient, you operate the patient. This was operated upon in emergency and saying that it was a compartment syndrome. And the surgeon, unfortunately, he wasn't really trained for that. He did this fixation, and you can see he put up this Tibia plate on this proximal fibula. And obviously, there was a foot drop. So this is how on the second day, they came over to me in the hospital. So this is how they came over on the second day. This was the X-ray on the second day. This was the CT scan on the second day. I did this, after he comes, I did the CT scan with the implant. And somehow I felt I wasn't very happy with the implant. And I didn't have much of a picture of the implant and the fracture. So I went down and I removed the hardware. And this is what is the picture, as you can see. So I removed the hardware and I could correct the fracture. You can see I could correct the fracture after removing the hardware. Articular surface could be reconstructed reasonably well, which I knew about it, but still I wanted to be 100% sure what it is. The CT scan after the plate removal. So this is the CT scan after the plate removal. I got it done, and you can see here onto this. This was the earlier one. Peroneal now is the radiologist is saying that peroneal now is gone. This is the site of previous cortical screw. This was earlier before I removed it, and this is what the CT scan. As you can see, everything has been shattered with the two. This is the 3D big picture there, and there was a So I went down, did the posterior plate, did the lateral plate, corrected the whole thing, did the massive bone graft here. This is the circlage and this is why the plate. I removed this plate, PROF persisted. This is how it was corrected, and everything has been corrected where articular surface has been re-established and the bone grafting was done here. And as you can see, the axis was corrected. This is how it is into the valgus position properly. And then 6 weeks later, he came over. Everything is fine. Good range of movement, as you can see. You can see the excellent range of movement which is there. But there is a foot drop which is there. And then the whole thing is slowly depression is occurred. But still the range of movement is preserved. The patient is not very unhappy about it. Sorry, I think there is some mix-up. This is the other case which is there, where the surgery was done, and I'm trying to show this is the day 1, and this is 2.5 years. You can see in 2.5 years, again the articular cartilage, which was fairly good into the day 1 surgery. This articular cartilage appears to be frayed out. So this is what is the one which we are talking about, whether it needs anything to be done. So all these are the situations. This is the joint replacement surgeon. He got the same patient of the opposite knee of somebody else, and he did this. And as you can see, the posterior part has not been touched. So I feel do not depend on the MS distinction knowledge. My very efficient high volume knee surgeon, who was not up to the date with the day-to-day fracture of this, he had not heard Dr. SCHATZKER's new classification and everything. Couldn't really let go of this patient, and he really ruined this patient. And as you can see, the whole thing has been ruined. So this is all CM based. It cannot be. I open up the joint and I do it, because without opening the joint, this is not the good surgery. So in conclusion, bad fractures need all the tricks: reduction, graft, double plating, locking plate, extra posterior medial approach. Bad fractures need good surgeons, not lazy surgeons. And bad fractures need never say die surgeons. Never trust all what we say all the time. It may be true in our hands at that time, not all the time, in all the hands. This is why I'm saying it, is because when I've been traveling and in different parts of the country for many years, and when I go after about 10 years and say something which is totally different than what I said 10 years back, they said, but sir, 10 years back you came and you said this. So the science is changing. Unless all of us are going to change dramatically with the changing science, we are not going to treat the patient properly. Thank you very much.
We don't hear. Tanna sir, thank you very much for this talk. And I can only say that 10 years later, you come and tell us that you treat all these patients by plaster. We will follow whatever you are saying.
It's never going to happen now. 10 years, it took much time for me.
For us, you are the lead master, and we will believe you whatever you say.
Thank you. Thank you.
Yes, sir. Now we request Professor Sharat Rao to present his talk, and then maybe time for some questions, and then we take.
Rajiv,
Yeah.
Rajiv, I have 2 or 3 cases. Do you want me to discuss the case or then show the cases?
It would be better if you discuss the case.
Yeah, I will show you one case and then discuss with the faculty.
You put it to the faculty, more so since we have Joe SCHATZKER and Professor Sharma and
Yes,
Professor
I will do that.
And get their opinion so that their opinion is carried forward by the others.
Okay, thank you.
Yeah. So you put it amongst the faculty itself.
Yeah. Are you able to see my screen, please?
Not yet.
Not
Now
yet.
yes. Now yes.
Okay, I have to just go through. Is it full screen now?
Now it is. Yeah, now it is.
Okay. So thank you, Rajiv. Thank you for giving me the opportunity. I think this is a learning process. It's a lifelong learning for every orthopedic surgeon. And we still think that we are perfect in everything. We are still not. And this is what happened to us in the course of our learning of proximal tibia fractures. This is a 58-year-old patient, no comorbidities, met with a RTA, an isolated injury. And this was the injury. So this was the limb as you expected. There is a lot of soft tissue injury. The blebs, you can see the blebs which are hemorrhagic, and also some of the blebs which are non-hemorrhagic blebs which are present. We all know that how to treat these patients now when you have such a soft tissue injury. And we put a X-fix and wait. How long to wait is still a dilemma, and you always wait till the wrinkle sign appear. So he was on an X-fix. Naturally, all the steps were followed. CT scans were done after the spanning X-fix application. And this is the stage where...
Sir, can I interrupt you here for a minute? There is a question from the audience.
Yes.
Now, supposing this patient had a compartmental syndrome,
Yes.
how would you treat them? Whether you would fix it, or you would do a fasciotomy and wait, or what would you do? This is from Harish Murthy.
Yeah, Harish Murthy's question, that is the answer for this, the entire case. If you go through the case, you will see the answer. Okay, and I don't think patient had a compartment syndrome in this particular case.
No, in case supposing patient has, then what to do? That's what he.
If the patient has a compartment syndrome, I will do a compartment release with the X-fix. I don't go in for a fixation at present because I don't know what is the status of the muscles at that point. And if there are muscles which are which doesn't have blood supply, and if you leave them, the chances of infection is high. So usually I do a compartment syndrome release, put an X-fix, wait, and then come back.
Okay.
Now this is the wrinkle sign. Is the patient on the table, underwent fixation. This is the fixation. And this is what happened on the 4th post-op day. And again, we started the procedure of debridement. This is the debridement. In spite of waiting, this was 18th day we operated on this particular patient after X-fix application, being 100% sure that there was a wrinkle sign. And finally, the plastic surgeons have to intervene. This was done. There was a small sinus which has developed in this particular patient. And this is after an year or so. Then he got its implant removed because of the infection. Now the infection has subsided. This is the status. 4 years down the line, he is ready for bone grafting. Now my question to the panel is, where did we go wrong? Why did the whole thing happen? Chandram Shetty sir, can you answer?
Yeah, that's, no, if you go back to the first X-ray. First X-ray as such, yeah. You see the fragment, the posterior part of there is a posterior fragment which is there, and you have fixed a plate medially and laterally, if I am correct there.
Yeah, as far as fixation is concerned, sir, there is no question. The question is, why did the soft tissue behave this way?
No, soft tissue, every fracture, as SCHATZKER rightly said, it is a soft tissue injury. So the surgeon has to be very, very definitive that the soft tissue has really been controlled, and then you get in. But you said already 18 days has elapsed and there was a wrinkle sign, and we saw the limb which was correct, which has really subsided. So it was a chance which you took, but it had to be done. There was no other way. So it is unfortunate it has happened. I don't know why it happened, because most probably the soft tissues hadn't healed properly.
I have a question to the panel.
Avascularity had set in. That's why there was infection.
I have a question to the panel. How common is the compartment syndrome in proximal tibia fracture without a vascular injury?
5 to 7%.
It is about 10%. I was talking about compartment syndrome recently. I have gone through the literature. It is about 10%.
Was he a diabetic, Sharath?
No, no comorbidities at all.
Smoking?
No.
Very difficult to explain this, really. I don't know if Prof. SCHATZKER will have an opinion on that.
No, I think, Sharad, you say there is no compartment. So that is why we
No,
closed
no.
the chapter there.
There was
Now-
no compartment syndrome.
Now, obviously, even if you waited for whatever 12, 15 days, and this has happened,
Yes.
in a retrospect, now we can say you still went ahead a little early. In a retrospect, probably as an operating surgeon, I would have done the same thing.
Yes.
After 15 days you went in, that was perfectly all right for timing. But the way it has turned out to be, probably we went down a little more early when the skin had not yet completely recovered. And that was the second trauma which really gave this ischemia. So now at this stage, if you went in, I don't know, at this stage did you go in?
Yes, this is the stage. His external fixator is
The swelling has not gone here yet.
okay. So do you think
But
that
if you are talking about at this stage you went in, still
Yes.
the limb is very, very swollen.
okay? So you still think these wrinkles are not sufficient
No,
enough to go in?
they are not enough, I think.
So do you think is early surgery itself is the main cause
yeah.
for this?
As I say, 15 days is a good time. Quite
Yeah,
a lot of
18
us
days,
will go in,
especially-
but in a hindsight, probably
Yes.
it is the only cause. And as you can see it here very well, the whole limb is swollen still. Quite a lot too swollen.
Can I just
think-
make a point?
Yes, Ajit.
Yeah, and I think Barei and group have actually written up about this. If you go in early, you would get wound infections, you would get infection at the site, but not skin breakdown like this. It has been our experience also where we went in thinking the wrinkle sign had come a little early. We have had a few cases of infections, but nowhere so severe wound breakdown as such.
The patient had a lot of hemorrhagic blebs. These hemorrhagic blebs represent that the entire skin is peeled off from the soft tissues. So do you think when you have a hemorrhagic blebs, do you think you have to give some more time before you operate?
18 years of one of us, 18 days is quite long.
No,
So I still have a lot of confusion about differentiating compartment syndrome from soft tissue injury in especially proximal tibia fracture. Looking at only the swelling appears huge. And naturally, when you dorsiflex the foot, you will have some amount of pain, which is present. And most of the time, it is, I think, soft tissue injury which is important. And if a surgeon goes in for a fasciotomy, one has to be very careful because the skin which has got blebs, which has got separated, and if you put an incision over it, it is likely to necrose further. So it's very important that a surgeon differentiates a soft tissue injury in a proximal tibia fractures from a compartment syndrome.
Sharad, put this question to Professor SCHATZKER.
Professor SCHATZKER, I would like to know how common is compartment syndrome in proximal tibia fractures without vascular injury. Number one. Number two is if there is lot of blebs which are hemorrhagic and which have got clear fluid, are there chances of he developing a compartment syndrome? These are my two queries.
Professor has to unmute.
Dr. SCHATZKER, unmute.
Thank you. Thank you very much. Thanks. I didn't realize that I muted myself. Well, look, the diagnosis of a compartment syndrome is clearly based on clinical manifestations, largely symptoms, and a compartment pressure measurement. Today, we can diagnose this very precisely. How common it is? Common enough to recognize that if you have the slightest doubt, measure the compartment pressure. Vascular injury does occur, of course, but don't mix up a vascular injury and a compartment syndrome. A compartment syndrome is the soft tissue manifestation of a soft tissue injury which has begun to swell and which has developed an intracompartmental pressure, and if it is not released, you'll get muscle necrosis. So how do you diagnose a vascular injury? You don't do a compartment pressure measurement to diagnose a vascular injury. We're talking about two different issues. Vascular injury, you need angiography. Compartment syndrome, you need compartment pressure measurement. And I can tell you it is far better to make the mistake and decompress a compartment than to allow a compartment syndrome to develop to the point where you get muscle necrosis. Because once that happens, it almost always leads to infection, particularly if you choose to operate at that time. Now, to come to your case, at this point, you're certainly not ready to go ahead and do any surgery with hemorrhagic blebs. It's a manifestation of the severity of the soft tissue injury that this patient sustained. If you haven't measured the compartments, I can't tell you whether the patient did or did not have a compartment syndrome. If he did have a compartment syndrome and you now come to do surgery, you will encounter necrotic muscle and you will know that you have missed it. And the final point I would like to make, it is far, far better to end up with some articular and some bone deformity and no infection and an intact soft tissue envelope than to take the risk and end up with major postoperative complications. They occur not only, well, certainly the timing is crucial, and it is given that you have to be delicate when you operate, not to leave damaged tissue.
Thank you, Dr. SCHATZKER. Do you think this is the limb position which is acceptable to open up now?
I would say you're far better not to go ahead till you saw the horrendous blisters which this patient had. It tells you the severity of the soft tissue injury. But may I ask you, did you measure the compartments?
No, we clinically looked into the fact that passive dorsiflexion, how painful it is, and there was no clinical evidence. And in every center, we don't have the facility to measure the compartment pressure.
Well, if you don't have the fancy up-to-date gadget, I can tell you that you can make your own compartment pressure measurement instrument. If you have a blood pressure cuff, it's very easy to make one.
Yes, we know that. We do it now.
So, I appreciate that, the fancy new gadgets cost money and are not available everywhere. But compartment pressures were an issue before these gadgets were developed, and there is a way. And I must tell you that clinically it is not enough. If you have a patient who has visibly a high velocity injury, measure the compartments. because you will miss.
Here, there was no compartment syndrome because even after 18 days, when we went inside, there was no muscle necrosis.
Well, fine, I accept that.
Sharath, can I just come in? Sharath, 1
Yes,
minute.
sir.
Sharath.
Yes, sir.
No, the compartment syndrome as such, with all respect to Dr. Sharath, it is a clinical entity. It is a clinical entity. When you initially said there was absolutely no clinical sign of a compartment syndrome, there was no stretch pain, except that those bleps were hemorrhagic, which is an indication compared to the clear fluid, which is an indication that the deep muscles are involved, that there is an injury to the deeper tissue. And it is still variable in our own, all the compartments, all the major publications which have come in. The importance of measuring the compartment syndrome as a compartment pressure as such is variable. It depends on the blood pressure, on this diastolic blood pressure as such in many of the patients. So is it mandatory that one should really depend on the clinical entity, or the compartment pressure has to be measured? Dr. SCHATZKER, is it very legally? Is it because many of the legal publications have come in that compartment pressure need not be measured?
Well, I would disagree. Look, it is clear that with the amount of swelling this patient had, he would have a great deal of pain. And I am sure that the leg was tense and swollen. And I'm sure that you can't just depend. Pulses, of course, can be present, so you can't go by the fact that he had distal pulses. So the fact that he didn't have a great deal of pain clinically when you stretch the compartments, for me, that is not enough. If you have a high velocity injury, the compartment syndrome can develop under your very eyes and you can miss it. So I feel it is essential.
Yeah.
I can give a comment. Every hemorrhagic bleb in a patient may not represent compartment syndrome. It may represent the soft tissue injury. Yes, there is a definitive soft tissue injury. But for compartment syndrome to be proved, as Professor SCHATZKER said, when you have a huge limb with lot of swelling, naturally you need to get a measurement of the compartment, which in any setup may be much easier with the recent weak technique, which has come out, where it is simply you can measure the compartment.
Now, Sharath, it is already so many months. Now, yeah. Are there any telltale signs of an old compartment?
In the patient when we opened up? No.
Now it is already 6-8 months. So what is the foot now?
No, his dorsiflexion, plantar flexion, there is no problem at all.
So that means there was no compartment at the moment.
There was absolutely no compartment. This is
this is purely the wound which gave way.
Yes. You can see the muscle, how good it is. Even after there was the necrosis of skin was much more than that of any muscle necrosis. So its entire skin was just peeling off from that area. And that was the issue. Maybe retrospectively thinking, maybe the incision site was too near because there are two incisions. One is posteromedial and the other one is anterolateral. So does that also matter, especially when you have a situation like this? Professor Tanna, sir.
I think it is a speculation. Normally, we always do these two incisions. It never gives trouble. So there is no reason why it should give a trouble into one case otherwise. So I don't think it is the incision. It is probably the vascularity of the flap.
Yes.
And as you can see, probably into those bullies which we have shown, there is a small amount of a hematoma collection, what happens in a pelvic fractures. वो क्या बोलता है वो something that do which something what is it? I forget the name. In a pelvic fracture, you get a hematoma also.
Moral level lesion.
Yeah, about the moral level. Something like that. If you go back to your bully things, there is a big amount of things which is seen onto the lateral side.
Yes. Yeah, I think it's most of the soft tissue injury which has occurred. I think looking at the blebs, we should have waited for some more time before we took a decision of opening up. I think we are very careful nowadays in taking up for surgery after, especially when we have seen hemorrhagic blebs. We wait till we feel that it is all right. Other blebs are fine. Only the swelling without blebs or blebs with a clear fluid are fine. But the blebs with the hemorrhagic fluid, I think, depicts a solid damage to the superficial structures, especially the skin. And as Professor SCHATZKER said, always rule out the compartment syndrome in these cases. Maybe we have been lucky that this patient did not have a compartment syndrome.
And Sharan,
he's happy now. He is due for total knee replacement.
And Sharan, with the experience of revision of the injuries, what I showed so many of them, I feel that it is much easier to revise the knee joint, which has been malunited, than to really go through this cycle. If you do it after 2 months where the fractures have healed up for about a month and a half, maximum you'll have to do is the intra-articular osteotomy. But you will be in a better position skin-wise, then probably you will still get a better knee.
That's very much the same point I made.
Word of advice from the experienced surgeon. Yes, sir.
Okay.
So thanks, Sharath.
Thank you, Rajiv. Thank you very much
No, it was very nice of you. We wanted you to have an interaction with Joe SCHATZKER, which you did when he was here 3 years ago, and we all liked it very much. To SCHATZKER sir, Sharath Rao is one of the most intelligent and academic surgeons from Karnataka.
Academic surgeon. It's a new word.
And one or two more questions from the audience before we close. One question is the role of bone cement. One doctor is asking whether we can use bone cement instead of bone graft. That is one. And second is, Professor SCHATZKER sir, you said that the screws should be at least 1 centimeter below the articular surface. So where should the raft plate screws be placed is another question that one person is asking.
As far as using bone cement to hold up depressed articular surface, the bone cement is too rigid and it will lead to mechanical failure of the overlying articular cartilage. I published on this many years ago. Using bone cement, it is far too stiff, far too rigid. And this is exactly why I made the point that if you're using rafting screws, particularly if they are combined with angular stability, they become far more rigid. You must leave a cushion of cancellous bone, which, how thick? Probably no less than 8 millimeters, because what we have called chondrolysis, the result of trauma, is mechanical destruction of the overlying articular cartilage because of stiffness. So this is the risk that we run into today using angular stability and using screws which are too thick, because the thicker the screw, the more stiffer it is. And if you combine it with a plate without any motion of the screw head and the plate, it becomes that much more rigid and that much more likely to result in mechanical destruction of the overlying articular cartilage.
So thank you very much. And Dr. Narendra will personally deliver the vote of thanks. And we request all of you to make yourself available, maybe in future times as well, because we have got excellent comments from all the delegates that they were very fortunate to listen to Professor Joe SCHATZKER, Tanna and Sharath Rao. And with this request, I sign off and Dr. Narendra will call the vote.
Good evening all. As all good things come to end, so is this virtual webinar on proximal tibial fractures on behalf of Bengalaru Trauma Course 2021. At outset, thank our faculty speakers, Professor Joseph SCHATZKER, Professor D.D. Tanna, Professor Sharath Rao. We are all enlightened by your presence, wisdom, and knowledge, sir. We are thankful to our moderators, Professor Shantaram Shetty, Professor Rajiv Naik, Dr. K.V. Rajendra, Dr. Ajit Kumar, and a special thanks to our organizers, Dr. Chandrasekhar H.S., Dr. Satish Rivega, and a special thanks to our scientific committee, Dr. Uday Kumar and Dr. Ram Subba Reddy. Our heartfelt thanks to our audience for their active participation and unflinching support for this webinar. We move to the end of this virtual webinar. Thank you. Thank you, one and all.
Thank you. Thank you, Professor SCHATZKER. Nice to see you again. Dr. Tanna. Nice.
Thank you very much, gentlemen. It has been a pleasure. Very interesting session. Thank you.
Thank you.
Thank you. I think, Professor SCHATZKER, it's time for your breakfast.
Thank you.
Thank you and good night.